It is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy before studying the continuous infraclavicular block. Like the single injection infraclavicular block, the continuous infraclavicular block is used for surgery of the arm distal to the shoulder. Because wrist and elbow surgery requires all the cords to be blocked, and postoperative pain management of these joints also require all three of the cords to be blocked, the continuous infraclavicular block has proven disappointing in clinical practice. The reason is that all three of the cords are blocked with the initial relatively large volume primary block, but only the cord on which the catheter has been placed seem to be involved with a smaller volume continuous infusion. This leaves the other two cords unblocked, and relatively large volume boluses are needed to recapture blockage of these cords. Most local anesthetic agents have been used for this block. The preference of this author is to use 15 to 40 milliliters of ropivacaine, 0.5 to 0.75% as initial bolus, followed with 5 to 10 milliliters per hour continuous infusion of ropivacaine, 0.2%. It is essential to allow large patient-controlled boluses of 10 to 15 milliliters every 60 minutes to recapture unblocked cords in the post-operative period should this become necessary. The patient is positioned in the supine position with a hand placed on the abdomen. After skin preparation, the area is covered with a sterile fenestrated transparent plastic drape. The surface landmarks are similar to those of the single injection infraclavicular block. One soon, the width of the patient's thumb, medial, and one soon caudad of the coracoid process. Another approach is one soon caudad on a line from the midline of the clavicle. The circle here indicates the coracoid process. Many authors have different approaches to the infraclavicular block. Of note is the more medial to lateral approach of Admir Hadzik and Elaine Bourget, the more superior approach of Rob Ra, which is fast becoming the preferred approach, and the more paracoracoid approach of Kurt Wiffler. The skin and subcutaneous tissue down to the level of the fascia that surrounds the major pectoral muscle and the intended path of tunneling is thoroughly anesthetized with lidocaine and 1 in 200,000 epinephrine. The epinephrine is added to reduce skin and subcutaneous bleeding. The insulated 17 or 18 gauge TUI needle attached to a nerve stimulator set to a current output of 1 to 2 milliamps, a frequency of 2 Hz, and a pulse width of 200 to 300 microseconds is aimed medially towards the interscalene groove. Penetration of the fascia surrounding the major pectoral muscle can clearly be seen on this recording. When the appropriate cord of the brachial plexus is encountered, the medial cord in this case, the nerve stimulator output is turned down to between 0.3 to 0.5 milliamps. This confirms accurate needle placement, but it does not guarantee accurate catheter placement. It is important not to inject any conducting fluid like local anesthetic agent or normal saline through the needle at this point, since this will serve to render the stimulating catheter placement impossible. The notion of opening up the space is not based on scientific fact, but more fantasy. In real-life tissue, this fluid merely infiltrates the tissue and causes local tissue edema. The angle and depth of the needle can clearly be seen on this recording. The bevel of the needle is always pointed in the direction that the catheter is intended to go. The needle is now on the posterior cord of the brachial plexus, and the pinky moves posterior. The nerve stimulator is set to 0.5 to 1 milliamps, an output comfortable for the patient, and attached to the proximal end of the stimulating catheter. Note the broad black mark on the catheter, which indicates that the catheter tip is situated at the tip of the needle. The catheter is advanced beyond the needle tip, and if the motor response disappears, it simply means that the catheter tip is moving away from the cord. Withdraw the catheter tip carefully to inside the needle shaft. Make a small adjustment to the needle, such as turning it clockwise or counterclockwise, or advancing or withdrawing it slightly, and advance the catheter again. Repeat this maneuver until the motor response remains constant during catheter advancement. Advance the catheter for 3 to 5 centimeters beyond the needle tip, but not more than 5 centimeters. Remove the needle without disturbing the catheter. A special tunneling device can now be used to tunnel the catheter subcutaneously, or the Tuohy needle and its stylet can be used. Tunneling is essential to prevent catheter dislodgement. The skin bridge may be used for short to midterm catheter use since this can facilitate easy catheter removal. The price of this is that of a higher incidence of leakage around the catheter. This leakage may be offset against tunneling without a skin bridge, which may in turn make catheter removal slightly more difficult. The snap lock is attached to the proximal end of the catheter. The nerve stimulator, set to an output of 0 milliamps, is attached to the snap lock and the nerve stimulator output is slowly turned up until a muscle twitch can just be seen. Local anesthetic agent or any conducting fluid such as normal saline can be injected through the catheter and the muscle twitches will stop immediately once the injection is started. This constitutes a positive Raj test that gives further assurance that the secondary block will be successful. The snap lock and catheter are attached to the stat lock, which is attached to a convenient place on the opposite side of the upper body. Catheter removal is after the patient does not require the continuous block any longer and after full sensation has returned to the limb. Any radiating pain during catheter removal may indicate that the catheter is coiled around a nerve or cord, and this situation should be managed with utmost care. Remove the catheter by stabilizing the proximal part and first removing the distal end from the skin bridge. Once this is done, keep the catheter sterile and then remove the remaining catheter.